Well, welcome and thank you for joining us here at the World Stroke Congress Fellow TV. It is my privilege today to interview Dr. Kevin Sheth, who's a top-notch physician scientist. Not only is Dr. Sheth the founding chief of the Division of Neurocritical Care and Emergency Neurology at Yale, he's also the vice chair of clinical and translational research in the departments of neurology and neurosurgery. And my understanding is also the current PI for two NIH neuroscience networks, NeuroNext and StrokeNet. Dr. Sheth, you've been awarded several grants, and it sounds like most recently from the NIH and the AHA. You've authored over 250 publications and have editorial roles in neurology, stroke, and neurosurgery. Can you summarize for us, your past and current research interests and pursuits?
Yeah, I'm, as you know, I'm a critical care and stroke neurologist. And over the course so far of my career, I've been interested in really patient-centered research, trying to take new in the broad areas of stroke and brain health. And for much of my career, especially the first many years, that was really focused on acute treatments, especially for the populations that I took care of, critical care and acute brain injury populations, acute stroke, through trials like glyburide for large infarction, brain edema, acute brain hemorrhage, and new therapies. We continue that work. And then in recent years, I sort of went through an existential crisis, which part of this may have been about sort of just getting older. But I had always had a longstanding interest in actually prevention as well. And I realized that there were a lot of elements that were these entities were not so distinct. And so in recent years, our group has really been interested in stroke prevention as well. So fundamentally, I would say clinical trials, translation, um, and translation into the communities of sort of new approaches towards stroke prevention and stroke treatment.
Fantastic. So I think that brings me to my big question is, you're a physician, you're obviously heading the neuro ICU, but you're also a researcher. And how do you balance your roles as a physician and a researcher? And what is the ideal balance?
I have to say, I think everybody has a different take on this. I certainly have my own, which is that when you say balance, I don't know if you mean balance or another phrase, sort of work-life balance. And when people say this, I always find that sometimes it implies almost that it's an either or. And I don't know. I think for a lot of that it is necessarily an either or. I mean, I really see trying to pursue things that I have the privilege to pursue that I'm excited about as being integrated with one another. And having a lot of times the research interests that I had really were integrated into clinical care and vice versa. And I would say the clinical care was integrated into my research time. And so these things became very fluid. And when it even comes to my personal life and my sort of non-professional life, I really, I have the ability, I think, and try to make time to be able to go my son's soccer practice if it's in the middle of the afternoon on a week when I'm not in the intensive care unit or taking stroke call. And on the other hand, I'll frequently, I might mean that I'm writing a grant at 9 o'clock or writing a paper at 9 o'clock at night. And actually, I don't see that as a problem, as a burden. I actually embrace all aspects of that. And so I think, I found that to be really great. There are practical considerations, of course, with time management and being efficient and all these things you can't be everywhere all the time. I actually found I'll say as a neurointensivist, that the field itself really can facilitate doing research and doing other things, because of the built-in time management that's there in a sense. So I'm always encouraging. I think, I think as stroke neurologists and as neurointensivists, I think even more people can get into research.
Excellent. And I love that. I love the fact that you said it's not an either or, but, sort of fluid, but you also addressed, practically there are implications to it. How do you, my question is, do you sleep? And how do you, where do you find the time? So it can definitely be a challenge. And I think we're truly interested in your work on the world's first FDA cleared a truly portable MRI, which it sounds like was a result of a phenomenal collaboration with both engineers and doctors, including Dr. Siddiqui of Hyperfine Research. Can you share what that process and experience was like for you and how you were able to get involved?
Yeah, just talking about some of that work that we have been doing we've been interested by virtue of studying stroke and brain swelling, and being a neurointensivist, being interested in neuroimaging has been part and parcel with that work for many, many years. And I would say not just our group, obviously, there's an entire field of people that are interested in trying to, in new neuroimaging methodologies to use devices as a monitor. So I think that's been a long-standing interest, again, from our group and from others. And we had been in the space of looking at non-invasive ICP and non-invasive measurements of the brain, within our group. Several years ago, about 5 years ago, we happened to make this connection, not just within a couple of academic groups that had been working on this on the physics and engineering side, but actually a startup company, Hyperfine at the time, that was really starting from a blank sheet of paper, and that really we're going to develop the technology and commercialize it. And I'd really want to recognize really what is a incredible team of engineers and founders at the company that has a long track record of producing innovations that can actually be deployed into the world. So we started working sort of hand in glove maybe about 5 years ago, from the conceptual model to a prototype to clinical deployment. This work was done closely with them, but it was also independently supported by the American Heart Association High Risk, High Reward program and the NIH. And ultimately, to go from a concept to a prototype to clinical deployment, I mean, that's very exciting. And these things can take decades, but this really happened in less than 5 years. So that's been very exciting. We've imaged hundreds of patients. We even did so during the COVID pandemic. And to be able to see some of that data actually really serve as the primary application for FDA approval, I mean, that's been really exciting. And now we're seeing other people use it, right? So that's fantastic.
We're about to get the first one here in Houston as well shortly, but we'll see. It's not in our institute from what I know. So, the work that you're talking about, and I think just getting was recently published in Nature in August of this year. And you spoke earlier at the Congress about, about the role in what your findings were with the portable MRI. What I really found interesting and really asked you to your part was about its role. The fact that you said it would not replace conventional MRI, but perhaps allow for imaging in other circumstances which were not previously possible, right? So what, in your view, is the ideal role for this low field portable MRI, or SWOOP, I hear is the street name it goes by?
I think that's right. I think that's the hyperfine name for the device. I mean, I think first of all, what I would say is that I think we're in the very early days in many ways. I mean, I'm hopeful. Very optimistic that this is going to really create a whole new field of neuroimaging, actually. And I'm looking forward to seeing how the broad community will come up ideas, some of which we haven't thought of the best way to use this really exciting technology. Having said that, I think there absolutely, I think in select cases, be a role to replace neuroimaging in certain situations. For example, I think some of our data shows that if you're trying to rule out hemorrhage, for example, or to rule in hemorrhage for a patient that you're suspicious of as having an acute neurological change, it can be really, really helpful. If you have patients that can't travel safely, and then you're worried about devastating brain injury, or they can't travel for other reasons. I think our initial paper in JAMA Neurology, it showed that really all of these settings are definite use cases for the device as it stands today. So I think detecting brain hemorrhage, sensitivity and specificity is quite good. I think that detecting mass effect and acute neurological change, I think it's quite good. I think using it for patients who can't travel to conventional imaging or not in a location where they have access to conventional imaging, I think that can be another use case. Those are ready to go today. I think we'll continue to learn from the experience at multiple centers and continue to understand what the limits are, those limits that keep getting pushed of being able to identify and characterize these pathologies. But then I think what we're also doing, I think when I say we, I think all of us, our group and other groups around the world, I think we're going to start pushing new boundaries for where the device can be used as well, actually, where conventional systems just have no chance of going. For example, doing serial examinations or to be able to use the device in novel locations. So I think we're going to hear more about that in the weeks and months to come.
And then I know the fellows here, we were debating, the role really, I think, and you guys looked at ICH more in the subacute phase. And is there a more acute role of MRI or MRA? Is there capability to do an MRA with this machine?
There are a lot of advantages that really come with going to a low field magnet, right? All of the barriers that come with high field really melt away. As you know, I won't walk through those, but there are many of them. But it does mean that at every level, you need new development and new innovation. So as it stands today, there's not FDA approval. There's not a clear path in hand for, for using contrast. You have to figure out what kind of contrast agent you would look, how the image acquisition and processing would be. I can tell you there's a substantial interest in that, and there is work being done to develop that currently, but it doesn't exist in hand today.
And non-contrast MRA, is that something that this machine or at this time this technology is capable of doing, or we're not quite there yet?
I would say not quite there yet. Yeah,
Gotcha.
but all great questions, all areas we'd want to go. Certainly, you mentioned acute imaging. For example, a lot of the hemorrhages were subacute hemorrhages at the time of imaging, but we've actually been able to use and deploy the device in the emergency department as well for patients who come in with acute injury. And we can see certainly that there is a role there. We're able to recapitulate some of these results, and we'll look forward to extending the capabilities, I think, in that area as well.
Excellent. And then, a few more questions. I know we're a little short on time, but I saw that in your paper, your group had enrolled both ischemic as well as hemorrhagic stroke patients, but the findings really were not reported for the ischemic stroke patients. Is that a paper we can look forward to? And would you mind sharing like your preliminary, views or findings which you saw with ischemic strokes?
Yeah, absolutely. What you will see, there at least from our group, there are two papers that have been published today. One is the brain hemorrhage paper that you mentioned, and that's correct. The focus of that was on blood in the brain. That's absolutely right. There was an earlier paper published in JAMA Neurology about a year and a half ago that really was a broad series that included COVID and non-COVID patients, and you'll at least see sort of case level examples within that of a number of pathologies, including infarction, brain infarcts of various sizes and characteristics. We've presented some of this information as well at the International Stroke Conference and in other settings. And indeed, you can see using FLAIR, using T2, and more recently, even using diffusion, you can visualize infarction. The limits of that, the consistency of that, I will say you're absolutely right. You can look forward to that paper. It's on the way. It's on the way.
I will be looking out for it. And then, I know you probably mentioned this, but I want to hear it from you. Is this portable MRI compatible, with one of the reasons that, people don't get conventional MRI, pacemakers, AICD, metal in the knee and the hip? Is the portable MRI compatible with that?
Yeah, so I would say one of the things that we've been very involved with is actually, if you go back to sort of safety parameters and development for the conventional high field strength MR, those really date back now, some 15, 20 years plus. More recently, there's been work done. There's a paper in the New England Journal about something that we use in practices, which is using high field, a very particular high field setup for ICDs and pacemakers and so forth. At a low field like this, I would say the device is not FDA approved for that indication. And so there's not a formal approval. I would say just from my personal experience with the device, I'd say I have a high degree of optimism and confidence that the device will be able to safely scan those patients. The work and the data need to be assembled in order to demonstrate that scientifically, clinically. but I'm confident that we'll get there.
Excellent. So it sounds like lots of things to look forward to. Dr. Sheth, any last words or thoughts or, pearls, words of wisdom for our trainees in particular?
No, I think this is really, I mean, I see it as the beginning of a whole new field, actually. So I'm glad that, you're getting the device, get it, use it. When you get it, reach out to us. We'd love to work with you and anybody else in the field. I think one of the things that we've learned, even beyond the portable MR and these other projects, is that, when our communities really get together and we can put some of this data together in larger numbers and diverse experiences, we can really learn a lot more and learn a lot more quickly. So, we're excited to work with any group, and then we're really excited that you're excited about it.
Excellent. And, Houston does bring a lot to the table. We have a completely different patient population than the one you probably see up at Yale. So I think it would be definitely interesting to see, the things that we can come up with in collaboration. Well, thank you so much for your time. It was a pleasure having you here and speaking with you, and lots of things, great work and lots of things to look forward to, Dr. Sheth. Thank you so much.
Oh, Maria, thanks so much for having me. It was great to talk to you. Bye bye.
Take care, sir. Bye.